So that leads, after that preliminary discussion of sleep and its physiology, to our first recommendation in the algorithm. We're at node 2A. So in short, the recommendation is that after you've ruled out or managed the various causes of sleep disturbance, and if the patient has PTSD-related nightmares or disturbed arousals, we recommend you consider a trial of Prazosin as the first-line medication treatment for your PTSD patient. To my knowledge, we are the only algorithm or practice guideline with that recommendation. But we got it through our peer reviewers when we published our paper in the Harvard Review of Psychiatry, when it went through blinded peer review. So we made a convincing enough case, with them at least, for the reasonableness of that recommendation. Now, a little bit more background about the rationale for this. This noradrenergic component was first recognized by Murray Raskind and his colleagues at the University of Washington, and they reasoned that since it crossed the blood-brain barrier, it might be effective for these arousal symptoms. It's a non-sedating agent. Unlike a lot of other medications used for sleep, it doesn't work by a mechanism of causing sedation. It actually was first developed as a treatment for hypertension. It was marketed under the brand name Minipress many decades ago. It didn't prove to be a great treatment for blood pressure because you would develop tolerance, it turned out, to the blood pressure lowering effects. And after a few weeks or months, it no longer was lowering blood pressure. So we have moved on to other treatments for blood pressure today, and it's no longer used for that. It's also used to treat symptoms of benign prostatic hyperplasia. It has effects in the prostate, this class of drugs, including Prazosin. And again, it's not used much today anymore for that because better drugs have come along, like tamsulosin, that are more selective for the prostate area. Now, as I said, it's the only commercially available alpha-1 antagonist that crosses the blood-brain barrier, but doxazosin does cross it weekly. And it is a much longer acting medication. And there has been some research, including one placebo-controlled trial now, a small one, finding efficacy in PTSD. So we have that at the end of our algorithm as another option to consider in the same class as Prazosin for overall treatment of PTSD. To discuss the efficacy issues with Prazosin is now, we're at a critical point in this lecture today, because this evidence is somewhat mixed, as I'm about to share with you. There are 5 placebo-controlled randomized trials with Prazosin. The 5th one has not yet been published. In fact, the only way to see it is to go to clinicaltrials.gov and look at the data that they're starting to put up about this study. I'll tell you about it in a minute. But the 4 other studies are all published. They're all from Dr. Raskind's group in Washington, affiliated with the University of Washington. They were published between 2003 and 2013. This last study was a large, multi-centered trial, and those results have not, to my knowledge, been published or discussed in any meetings, but I've seen them on that website, and you can see them as well yourself if you go there. But the 4 published studies were all very positive. The impact on PTSD symptoms was mostly twice as great with the drug as on placebo, which can be translated to an effect size of 1 or 1.0. If you look just at the effect on nightmares, though, it was a 200% increase over placebo for the effect size on nightmares. That would translate to a 2.0 effect size. Now, to put into contrast, what do you think the effect size of SSRIs are on PTSD symptoms? In a 2015 meta-analysis of all the SSRI studies in PTSD, the effect size was 0.23. That was the mean effect size of all the SSRIs. That's only 23% better than placebo. So this evidence from these first 4 Prazosin trials is the evidence we have relied on for placing prazosin at the top of our algorithm. However, this fifth study casts a shadow on the others, a big shadow. No difference from placebo was found. There was not even much of a small trend in favor of prazosin on the measures that have been reported so far. They've only started to put up some data on the website, as they are required to do. No commentary or explanation has so far been offered by the authors of the study. No discussion. What do we think of these results? Why are they negative? We don't know. So should we change our algorithm preferring prazosin here for sleep, especially in the light that there have been years now of clinical experience added to it, and there are quite a few open label and other studies all supporting the effectiveness of this treatment. Maybe we should change the algorithm, but right now, until this data has been fully brought to public attention and analyzed, and given the considerable clinical experience that's been accumulating, we're keeping prazosin where it is for now. But keep posted. We recommend you keep checking the clinicaltrials.gov website, check with our website to see if we've decided to change our thinking on it. This is a work in progress. Now, the next issue is, how do you dose prazosin? This is a very important part of the talk. Probably the most important, since we feel prazosin is an important treatment, but you need to know how to dose it. A couple of studies have been published showing that 85 to 90% of patients who are put on prazosin are given a subtherapeutic dose, and the clinicians give up prematurely. The reason seems to be just lack of knowledge of what the protocol was that Raskin used in his 4 studies for dosing the patients. I'm going to share that with you right now. But there's also another barrier besides knowing the protocol, and that is that this protocol takes some time to administer. And time is one of the biggest barriers to the practice of evidence-based medicine in general. Anything that takes more time is something that clinicians are likely to reject if it means a change from what they've been doing, because time is very hard to come by. You have a very busy office or hospital care caseload, and if something's going to take more time, something's going to have to give, and it's easier to think, I can't take this time. I'm just going to keep doing things the old way that was faster, that I've been doing, and ignore the evidence. So you need to know how it was dosed in the original study. So here's how it was. First of all, there's 2 different protocols for the men and the women. We don't know why, but for men, you seem to need significantly more to get the same effect. So first of all, where are you going? You're going for a mean average dose at endpoint of 15.6 or about 16 milligrams. That was the average effective dose at the end of Raskin's 4th and final published study in 2013. That meant that half of the veterans needed more and half needed less than 16. And how did he get there? He went with 1 milligram at bedtime for 2 nights, then 2 milligrams for 5 nights, then 4 for 7 nights, 6 for 7 nights, 10 for 7 nights, 15 for 7 nights. So in other words, it took 5 weeks to get to the average dose, and then 25 after 7 nights on 15. That's the maximum he used in that study. Subsequently, he and others have reported using higher doses. Certainly going as high as 25 is reasonable if they're having no side effects and tolerating it well. That's key with each dosage increase, is are they tolerating it and having no significant side effects, yet their nightmares are not gone and their disturbed awakenings are not gone. The goal of treatment is to eliminate these disturbed awakenings and give them a smooth night of sleep. And that's one of the reasons people stop at earlier doses. Maybe they've been having a nightmare every night, maybe 2 or 3 times a night for years. And now after they get up to 4 or 6 of prazosin, it's down to only 2 or 3 nightmares a week. Wow, the patient is very happy. And the doctor may be happy too, but not realizing that if they keep going, the nightmares could be eliminated altogether. Because 2 or 3 nightmares a week and disturbed nights of sleep 2 or 3 nights a week is causing significant impairment and quality of life for many people compared to having excellent sleep. Now, in the Raskin protocol for the men, he also gave a mid-morning dose, usually about 10 or 11 o'clock. It's a short-acting drug. It's usually pretty much gone by morning. So to give some additional benefit for daytime symptoms, Raskin gave 1 milligram starting at week 2 for a week. Then he gave 2 milligrams for the next 2 weeks, and then he gave 5 milligrams for weeks 5 and 6 for the daytime dose, which gives an additional boost for daytime symptoms. Now, the protocol for women is roughly half of that at the end, although it starts the same. It starts with 1 milligram at bedtime for 3 nights, then goes to 2 milligrams for the next 11 nights, making a total of 2 weeks on the 2 milligram level. And then 4 milligrams for a week, 6 milligrams for a week. 10 was the maximum that they used in that study. The median dose that was effective was 7. And he also gave mid-morning doses to the women of 1 between weeks 2 and 3, 2 between weeks 4 and 5. You should be aware that there are a published set of case reports from 2014 where individuals received up to 45 milligrams at bedtime, believe it or not, for treatment-resistant patients who were able to tolerate that much until finally achieving excellent results. So there's a very wide range of dosage that you might find that you need. And there are some patients who really do improve substantially on 2, occasionally even 1 milligram, who are very sensitive to it. But if it doesn't work, by no means should you quit there. And this is why you get 85 to 90% inadequate trials, because the doctor may prescribe, take this Prazosin 1 milligram. If it doesn't work, go to 2, and come back and see me in a month or 2 months or whatever the usual interval you have for seeing your psychopharm patients. So over the course of the next week or 2, the patient gets no benefit. As a matter of fact, they may even think their nightmares are worse. So they stop taking it. And maybe when they come back to see you, they say this stuff didn't work. And if the doctor isn't really up to date and clear on the dosing protocol, he or she may agree and move on to another, probably much less satisfactory option, at least if we go by these first 4 Prazosin studies. All right, so that completes the discussion of the initial treatment with Prazosin.